So I think the main pitfall as compared to neoadjuvant therapy, because I think adjuvant really is a different kettle of fish, is that we may be overtreating some patients. So some patients perhaps don't need the additional adjuvant therapy after having had neoadjuvant prior to surgery. So I think we need better ways of actually selecting patients who require that adjuvant therapy, and these are perhaps the higher risk patients. But if you start off with perioperative therapy, I think you have to look at ways of de-escalating for patients who have a lower risk, because that is then your standard. And we could do so by, for instance, looking at the response of the tumor in the resected specimen after the neoadjuvant start of the therapy. And if you have a complete response, a so-called pathological complete response in the tumor, we know that those patients have a very good event-free survival. So perhaps that's the patient group that you can actually discuss with in the outpatient clinic whether they actually want to have that adjuvant therapy because they have a very small risk of recurrence of the disease. We could also use other parameters, so you could look at using, for instance, cell-free DNA analysis after resection of the tumor, also called minimal residual disease analysis, or MRD. If there is still cell-free DNA present in the patient, we know that those patients have a higher risk of recurrence. So that may be something that we could do in future. At the moment, I think the sensitivity of these assays is probably not good enough to actually be used in routine practice, so there's still some work to be done on that side. And then there's also the risk that some of these patients may not actually respond very well to the therapy that they've been given prior to surgery in the adjuvant setting. So if you look at the tumor and you see that there's a lot of residual viable tumor cells, so RVT as we call it, that may be an indication that this tumor is actually resistant to the therapy that you've been giving in the neoadjuvant setting. So you may then need to switch to a different type of therapy, or perhaps you need to add in other types of therapy like an antibody drug conjugate, or a second type of immunotherapy, or perhaps even vaccines directed against neoantigens from the tumor of the patient.